Hello, and welcome to this episode of In Discussion With from PharmacyUpdateOnline. Today, I'm talking to Shannon Nally about a project concerned with prescribing of chemotherapy by pharmacists. Please, could you start by introducing yourself?
Good afternoon, Christine. My name is Shannon. I'm a pharmacist working at Imperial Hospital Trust in London. And my background is involved in aseptics or oncology and haematology pharmacy especially. So I did my bachelor's of pharmacy in University College Cork. I then went on to do a master's in pharmacy in the Royal College of Surgeons in Dublin. Following that, I did a master's in clinical pharmacy back in UCC. And then I furthered my studies by doing a course in good manufacturing processing and supervisory management while I was in Limerick. And I'm a registered pharmacist with the MPSI and the GPHC. So that's where my background lies.
Now, you received the Best Poster Award at the recent EAHP Congress in Lisbon, and this was for your poster entitled Evaluating the Potential Clinical and Economic Impact of Chemotherapy Prescribing by Pharmacists in a University Teaching Hospital. What was the thinking behind this project?
So the inspiration for this project came from a spiraling cancer incidence and have a high prevalence of prescribing errors. We're seeing an increasingly multimorbid aging population. We have a paucity of doctors in our healthcare system. And these are all like prompting a review of the way the current labour force is managed and whether like non-medical prescribers such as pharmacists can alleviate some of these pressures within the healthcare systems. And like I see here at work myself, like the oncology clinics, they're becoming like increasingly pressurized. And we need to think of innovative ways to help reduce this pressure while maintaining and enhancing the patient experience. And we know that like chemotherapy prescribing errors, they represent a potentially serious risk to patient harm. And there's a clear need to investigate the impact of pharmacist prescribing in cancer services. And if we like, say for example, if we get the dose wrong when we prescribe something for a patient, like, so if we overdose, if we prescribe it too high, we're going to overdose the patient. And if we underprescribe, prescribing a dose that's too low, we risk the success of treatment and the success of therapy. So it's a very fine line. We have a very narrow therapeutic range to work with. So all these factors kind of played into effect when we came up with the design for this study.
That's interesting. Now, could you describe to us the design of the project?
So this was a comparative, prospective study that evaluated the clinical and economic impact that the provision of a pharmacist chemotherapy prescribing service could have at a university teaching hospital. And the results we got were compared to the same set of prescriptions that were prepared by doctors. So we had 155 patients. 155 patients both had two sets of prescriptions. So we had a set of prescriptions done by pharmacists and the same set of prescriptions were done by the doctors. And at the end of the study then, these both sets of prescriptions were compared. The errors were recorded. The errors then were presented to a peer review panel. And this peer review panel, they were all independent of the study. None of them took part in our study. 3 of them were consultants based in other hospitals. 3 of them were specialised pharmacists who did not take part in our study. We then classified all the different types of prescribing errors according to the PCNE classification for DRPs. And we also then got adverse drug event probability and severity ratings. And all of this then correlated into economic evaluation to see is it economically worthwhile for pharmacists to prescribe. So 2 aspects kind of were coined: the safety of prescribing and the cost of it.
And what were the results? What were your findings?
It's really important to bear in mind as well that the doctors did not know the study was taking place, and the pharmacists were blinded to what the doctors prescribed as well. So we had a double-blinded study for this as well. Our results then were really interesting, really intriguing results. So we had a total of 310 prescriptions, 155 from doctors and 155 from pharmacists. It involved over 1,400 medicines in the study. A little under half were chemotherapy drugs and a little over half then were kind of the supportive medicines. Oncology indications included like breast, colon, glioma, sarcomas. We had hematology regimens like lymphomas, leukemias. So we had a good broad range of regimens involved in our study. There were just slightly under 80% of oncology prescriptions and a little over 20% then being hematology prescriptions. About 95% of the prescriptions were electronic, with the remaining 5% being handwritten prescriptions. Not all our regimens are built electronically at our hospital, but we're getting there. Of all the errors that occurred, a little over half of them were from the wrong dose being prescribed from both sets of prescribers. Now, this is where it gets interesting. So a total of 128 prescribing errors were identified from the 310 prescriptions. Of these, 105, which is 82%, were from doctor-prescribed chemotherapy, and 23, which is 18%, were from pharmacist-prescribed chemotherapy. And for this figure, then we got a p-value of less than 0.05, so showing that our results were significant. 17.6% of the doctor-prescribed errors were classified with a high probability of causing an adverse drug event, versus 0% for the pharmacist-prescribed errors. Of note, 17 of all errors were classified as being severe, and these all came from doctor-prescribed chemotherapy. Pharmacists prescribed 0 errors that were classified as having a high severity score. And assuming then that the errors were not spotted and that they all reached the patients, we derived a net cost benefit utilising a pharmacist prescribing service, and the savings were over 1.2 million on an annual basis. So a lot of results gained there, a lot of information, and it's about getting this information out to the right stakeholders so we can actually do something with this knowledge now that we've captured.